Hello, I'm Aimee McClenahan from Stable Lab. Welcome back to the Innovator Circle. We are here in Florida on the eve of AAP 2016. Tonight you will see some familiar faces, but you will also meet our new innovators. The discussion has evolved as the research papers continue to be published, much of which supports what our innovators have been discussing over the last 2 years. Tonight we will focus on the practical application of Stable Lab as a tool for equine veterinarians to manage infections in an entirely new way. This is the Innovator Circle.
Last year we talked about, how we all believed in this test and how it's changed the way we practice. But I wanted to know, and I asked it last year, how do you convince practitioners, trainers, owners? And I've seen a trend recently where, in my case, owners are starting to ask for it. They're asking for that number. At first I had to explain what that number was, and now they're asking for it. I'm wondering, are you guys seeing that? The owners and the trainers are asking for that number?
It's remarkable. I can't think of another advancement in our practice that has been accepted so readily and almost turned around to the point of requested more frequently than is appropriate sometimes. And I think that's a reflection of the impact that this information has on backing up our clinical judgment. The clients don't always have a full appreciation for what's involved in developing a clinical judgment, but they understand the numbers. So
they want to hear zero.
It helps them.
Yeah.
It helps them to.
It's easy to understand zero.
Yeah.
Easier to understand zero, but the 3,000 really resonates.
Yes.
When you say zero is normal.
Especially when you say
and
zero
your horse is.
You hear the pause on
Right.
the phone.
Right. Yeah.
And it really resonates with them when and emphasizes how sick their horse is.
Yeah.
I let them hold the machine for the 9 minutes. I can go call a client, I can call my wife.
While their heart is beating
I could
faster.
call, Tim or Jan-Hein, and they're holding the machine. They love that.
That's hilarious.
I have to tell you, in cases where I've had it every 12 hours, that's the longest 9 minutes of my life. In some cases. And, over the last couple of years, we've been experimenting in our own way and in our own practices what SAA was, and 2 years later, 3 years later, I think a lot of things that we thought we knew, we know. There's a lot unknown still, but one of the things that we know today because of current studies that have been done is the magic number. By that I mean, what is an infection when you first see a number on your screen pop up? And we know for a fact that 50 means there's an infection. Now, how do you handle that is, where we go from here. And that's kind of what I wanted to open up with, is once we have a 50 and above, what do we do?
Really, for me, when I run Stable Lab and I get 50, and that's kind of where my comfort level is now again too. That tells me how aggressive we need to be. And I love that you had mentioned that one number, and I drill that into my clients' heads. The first number is really interesting. That's what I tell people. The first number is interesting, the second number is informative, and the third number is really informative. So I try to make sure that they understand that it is a series and that we're following a trend, and that's how we're going to treat the horse according to how those trends go.
One of the studies we saw was this past year was that SAA was 50 times more sensitive than a thermometer.
Right.
And that when I first read that, it didn't really register 50 times. Because we take temperatures in some cases 3 times a day because we know what fevers do and don't do. But to read that you are already using it that way, Erika, where your thermometer is still important, but not like that. And so what do you do with your thermometer? What do you do these days? Do you look at that SAA? Do you look at that?
I think that, I still use that thermometer for sure, and I still do CBCs for sure and fibrinogens. But, I'm a mobile guy, so I'm out there with a patient, and if I look at a horse that I have a question about at 10 o'clock in the morning, I'm not getting back to the office to submit the blood until 5 or 6 or 7 o'clock that night. I'm not getting my blood work back until the next day. Where Stable Lab has been a remarkable help for me in managing health and disease is that if I start, we all know the earlier we can treat something, the earlier we can make a really solid therapeutic decision on a horse, the faster they're going to get better. I mean, that's just common medical sense. And so if I can make a decision on that horse earlier, if I look at a horse and he's just not quite right, temperature is not helpful, but he has a 700 SAA, I know I'm in trouble at 10 o'clock on that morning, whereas I may have delayed treatment on that horse until the next day when I get my CBC and my fibrinogen back, because I don't have the luxury of being at a big clinic with instant laboratory results.
So Jan-Hein, when we talk about synovitis versus joint infection, initially when I looked at that, I was seeing low numbers in the joint, but you feel that there could be a false negative of some sort with joint and or serum?
The false negatives in joint infections as well as in tendon sheath infections is the one that has kicked me a couple times. And I am aware that now that both the serum and the synovia may be negative and there may still be infection going on. I think it's we call it a false negative. It's not a false negative, but because it's not there. The SAA is simply not there, and the liver is not reaction, or the body is not reacting to the bacteria that are in the joint and producing the damage there or in the tendon sheath. What I have seen in the course, and we've had quite a few that were 0 to start with, and in flushing the joint and in the development, in the course of the disease, of the infection, when we got it under control, it might go up to like 150 or 300 and then go down again. If it's gone up to osteomyelitis, if the bone would be involved, that it would just shoot up like crazy, and we would be much more aggressive with either limb perfusion or whatever. But in the later course of the disease, SAA has been a help for us. Do we have the right antibiotic? Should we be more aggressive locally? But in the initial stage, and I would say even the first week, it may be completely negative.
Yeah, it seems when we saw consistent elevations of SAA in the synovial fluid was horses that were coming in 4 or 5 days post-infection or weren't being caught right away. Those tend to be consistently elevated as opposed to a horse that you're getting 24 hours post-infection or less.
Yeah.
Did you
agree?
Did either of you monitor the treatment of that joint with SAA, serial SAA?
We tend to with blood more than the synovial fluid.
So talking about shipping, pre-shipping, post-shipping, Tim, do you rely on SAA for pre-shipment, post-shipment? Where do you lie in that?
I'm not using it so much for pre-shipment these days, although I think there's a valid reason to do that I would almost call that a pre-screening tool.
Correct.
Because we're starting with a healthy horse before shipment. But on the other end of transport, if they've transported for more than 10 hours, I'll use the SAA as a screening tool in certain barns that want to be very forward, or in our situation arriving at a competition where there's little room for error. If they've been more than 10 hours on the truck or involving the airplane, I think the SAA can really help us be ahead of things. If they're 50 or under, if they're 0, I'm happy. If they're 50 or under, I'll check them the next day for sure. If they're 50 Plus, I will monitor them again in 12 hours with the SAA, take an extra good look at them clinically, quick to reach for the fluids and the vitamins to kind of help support their system to dealing with whatever transport stress they're experiencing that's causing the SAA to be elevated.
You know, EIPH, speaking of performance horses, was something I don't have a good handle on yet as far as SAA. We still give antibiotics prophylactically for bad bleeders, for bleeders that have bled, visibly bled. And I want to get away from that, but I don't know how to do that yet, because some of those horses get ill. Some of them, you don't see anything till 3 weeks later, and it had to have been that bleed. But does anybody have any experience with EIPH at all, with the SAA?
I do. We, for me, and I don't know that this is right or wrong. This is how you start figuring out what's right and wrong, I guess. Right now, kind of my protocol is we test them at 12 to 24 hours after they bled, and this is assuming that we've seen visible blood. And see what the SAA is. If it's 0, we test again in another 24 hours to make sure. Horse clinically doing well, we might call it quits then and say, no, we don't need antibiotics. And if we see elevations, then that's when we would, I think antibiotics are indicated. I do think that would be a fantastic avenue to explore more, to figure out.
Yeah, I'd like to get away from that, but I don't know how to do that yet.
Mm-hmm.
So I do see a fair bit of EIPH, just for what it's worth. I certainly don't have the answers in terms of how SAA might guide us. In general, they're more often in the Western sport horses, but occasionally in a jumper. Most often I am seeing them in the 48 to 72 hours after they've bled. So I don't have oftentimes an SAA. They are at a performance, and then I maybe see them early in the week. So I don't have that early SAA, but by the time I see them, in the several dozen that I see a year anyway, the SAAs are invariably quite low. Obviously, those are the ones who either got some antimicrobials or got lucky and didn't get.
Or they cure themselves. They have an immune system.
We always forget that part,
They
don't
do.
we?
Yeah, they do.
They can.
How do they live without veterinarians day by day?
Two things. They have an immune
understand
system,
that.
and don't forget to look at the horse.
Does anybody know on gastric ulcers what the SAA is? I think that would be something really interesting in checking all our gastric ulcer horses, because that
I would think.
I checked a couple horses that have come in for endoscopy to be scoped for ulcers, and I've not seen a rise in SAA, but that's maybe just a handful of horses.
And I'm
I
just
would concur with that.
Yeah.
empirically, it's so common on the racetrack, but I don't see elevated SAAs all the time. But I'm assuming that most of those horses have some sort of ulceration. Do you guys, Korin, do you have a feeling on colics? I'm wondering, because it's something that we're still asking ourselves, and I don't think the answer's there. But how have you used SAA with colics, and do you have a feeling for it?
Sure. I don't know if I can say we're seeing distinct trends, but we try to take any colic that hasn't been colicking for more than 24 hours and check their SAAs at admit, and then whether they're surgical or not, at 48 hours and 96 hours. And are also looking at their serum amyloid A in their abdominal fluid. It's been very distinct and clear with horses with peritonitis, which is, for us in the referral practice, we can just put the abdominal fluid through the analyzer and have differentials and results right then and there, but I think it's probably beneficial for practitioners in the field.
What SAA numbers do you see in the peritoneal fluid?
They can hang out. We've had a couple that are in the 30s to 50 range, and those are usually some of our more brewing enteric pathogen horses. But we easily have them climb up to 3,000 or above 3,000 if they really have a rip-roaring peritonitis.
Is the serum SA higher than the peritoneal fluid SA in general on the same horse at the same time?
Certainly for the infectious components, so the peritonitis is. We've had horses though with normal blood SAs that have elevated abdominal SAs. It's huge for following up the post-ops afterwards.
Yeah.
It's been really beneficial to catch post-op complications, whether it's a mild pneumonia or an incisional issue, by monitoring their SAAs. And when to take them off antibiotics has been huge as well.
Do you see? Go ahead, Richard.
Well, I think that's a great point, Korin, because when we put a horse on antibiotics, when do you stop? So in the field, we're always wondering, where do we go 5 days? Do we go 4 days? Do we go 7 or 10 or 12 days or 14 days? And I think that recurrent monitoring of our SAAs has been remarkably helpful for me in deciding when to go. When I went to vet school back in 1792, we were told that you always want to treat them at least 2 days past the absence of any clinical signs of infection. And yet, I'm not sure that's always been that accurate over the years of practice. But if I see that SAA trending down, then I have a handle on how long do I need to continue my antibiotic therapy.
What about outcomes? Do we have a feeling about all this, equipment, all this testing, all these numbers? Are the outcomes better? Are we treating these animals better? Are they getting healthier faster? Are we? I know what I feel, and what I feel is that I'm judiciously using antibiotics. And by judiciously, it doesn't necessarily mean less. It means appropriate.
I would say, I work with primarily a referral population, but I think it does maybe improve outcome because the field veterinarians have the test and they're running it, and if they feel that, the SAA is not responding, or, they might be quicker to refer the horses into the hospital, and then, hopefully then the horses can have a better outcome.
I feel like we have a better outcome, even on non-referred cases. So it's been remarkable in that sense.
It is very helpful when you get the history of the horse and the referring veterinarian's been tracking the SAA, because again, the individual number doesn't mean as much as the trend. So I've had horses that veterinarians have been, say, treating for just a bacterial pneumonia, and they decide to ship it in. Day 1 or 2 after it ships in, the SAA really spikes. It's, in many instances, it's a precursor for what's going to come. And for the longest while, we all used to say, treat the horse and not the blood work. But I think that's changed. And we, at least for me, when I see an increase or a significant increase in the SAA, I know that there's usually significant disease there. I have 2 horses in the hospital right now that they're both afebrile, both have pretty severe pneumonia. One's a resolving bacterial pleuropneumonia. Their SAAs are up in the 2,000 range, but the horses are afebrile. And to look at them, you wouldn't know that they're sick.
It's obviously changed the way you practice.
Yeah, no, it's
even more so than before when you had.
Than before.
Yeah.
I used to think getting it back in 24 hours was a reasonable time frame, but that's changed. And not only for myself, but again for the owners, the trainers as well, because they're starting to become more aware. And I have some trainers that when they send a horse in, they want to know what that number is. And so it's definitely changed the way that I manage a lot of cases, especially for a lot of the respiratory cases that I see. Those cases that may be just on the cusp, that you're not quite sure whether or not there's an infectious component. See a lot of horses with inflammatory airway disease where we know that we need to treat them with some form of corticosteroids, but we're always a little hesitant to do that if they have a lot of thick mucus and you suspect that there might be a secondary bacterial component. It really helps me distinguish how aggressive or whether or not I can go ahead and treat those horses with corticosteroids safely.
Yeah.
So it's definitely changed the way that I practice and handle a lot of my cases.